Mustafa Hassanain. I'm an emergency medicine consultant with a special interest in POCUS. Today we'll talk about cardiac ultrasound, specifically acquiring basic cardiac views. So after this presentation, you'll be able to acquire basic cardiac views and able to identify different structures on each view. In echo or cardiac ultrasound, we use a phased array probe, which is a low frequency, high resolution probe with a small footprint, make it ideal to scan between ribs. The probe marker should be on the right side of the screen in a cardiac preset. Holding the probe is crucial for your comfort and the patient's comfort. You need to hold it like a pen and rest part of your hand gently on the patient's chest. If you hold it in a wrong way, it's unlikely that you will be able to obtain decent images and you might cause discomfort to the patient. These are common terms that we use while doing any type of ultrasound, which is sliding, rocking, sweeping, fanning, compression, and rotation. We'll talk about 4 basic views, which are parasternal long axis view, parasternal short axis view, apical or 4-chamber view, and subcostal or subxiphoid view. To obtain a parasternal long axis view, you need to place the probe in the 3rd or 4th intercostal space immediately left to the sternum. The probe indicator should be pointing towards the patient's right shoulder. As the name implies, you are cutting the long axis of the heart. This is what you should be able to see. On your right is your left atrium, and then the flow goes through the mitral valve to the left ventricle on your left side, and through the aortic valve, through the aorta or the ventricular outflow tract, left ventricular outflow tract. On the top side of the picture, you can find the RVOT, which is the right ventricle or the right ventricular outflow tract. This is a picture from a simulator. Again, on the lower right, you will find the left atrium, and then the mitral valve. On your left side, you'll find the left ventricle, and that arrow there is the aortic valve, and this is the aorta, and the top side of the screen, you will find the right ventricle. This is a video of parasternal long axis view. On the right side, this is the left atrium, left ventricle, and this is the aorta. On the top side of the screen, this is the right ventricle. Again, this is another video of the parasternal long axis view, and you can see the left atrium, the mitral valve, left ventricle, and your aortic valve there, and then your right ventricle at the top side of the screen. Notice that you can get the aorta as well in the same view, and this can easily differentiate between pericardial and pleural effusions based on where the effusion from the aorta. And that's one more video. Your left atrium and your left ventricle and your aorta on the right side, and the right ventricle on the top side of the screen. Notice here that the gain needs adjustment, and that's why you can see very bright white color. This is a snapshot of the parasternal long axis view, and you can see the left atrium, the left ventricle on the left, and the left ventricular outflow tract, or your aorta on the right side, right ventricle on the top side of the screen, and your aorta down here. To get a good parasternal long axis view, you need to identify or be able to define three structures in that plane: the mitral valve, aortic valve, and the cardiac apex. Otherwise, you might lose crucial pathologies. And of course, clinical correlation is always needed when you're doing an echo. Rib shadow. So if you come across a rib shadow, you might angle, or you might want to angle the probe obliquely to avoid that rib shadow. Also try sliding the probe towards and away from the sternum in the same intercostal space if you can't get a decent view. If possible, you can ask the patient to lie in a left lateral position, and that will bring the heart towards the chest wall and help you getting a decent view. Moving to the second view, which is the parasternal short axis view. So from the same position as before, what you need to do is to rotate your probe 90 degrees clockwise. Your probe indicator should be pointing towards the patient's left shoulder. As in the illustration below, you can get three different cuts. You can get the aorta or the aortic valve, you can get the mitral valve, and you can get the apex. In a parasternal short axis view, you're slicing the heart at the short axis level. And at this level here, we've sliced the heart at the mid-papillary level. So that's why you can see the two papillary muscles on the right and lower left. And this black hole there is the left ventricle. On your left side, you will find the right ventricle, and between them is the septum. Sliding the probe towards the patient's right shoulder or left hip, or sometimes you can get away with just fanning the probe. You can get different cuts and different levels at the parasternal short axis. So you can get an apical view, you can get a papillary muscle level, you can get a mitral valve level, which is called the fish mouth view. You can get a basal level or an aortic valve view, which is the famous inverted Mercedes sign view. So this is a picture of the mid-papillary muscle level. So you've got the left ventricle, which is the circle that you can see there, and then you've got fleshy structures on the right and the left of that circle, which are the papillary muscles. So this is a video of the parasternal short axis view at the papillary muscle level, and you can see in this view how the left ventricle is trying to contract. In this particular video, in the parasternal short axis view, you can get another view, which is the mitral valve or the fish mouth view. You can see on the right side that the mitral valve will be open during diastole and closed during systole. This is a video of the mitral valve or the fish mouth view. You can also get the aortic valve level or the inverted Mercedes sign view, as you can see here in that simulator picture. This is the aortic valve and you can see the Mercedes sign. So to get a good parasternal short axis view, you can more or less follow the same tips for the parasternal long axis view. So angle the probe obliquely if you find a rib shadow, or try sliding the probe towards and away from the sternum in the same intercostal space. And if the patient is well enough, ask him or her to sit forward or to lie in a left lateral position. Now moving to the apical view or the four-chamber view, you need to place the probe at T4-5 level or the nipple line, or feel where the point of maximal impulse is, and that's simply by placing your hand and see where the heart beats most. Your probe indicator needs to be pointing towards the patient's left shoulder, and this is what you will see in the apical view. This is a four-chamber, so on your lower right, this is your left atrium. Upper right, this is the left ventricle. Upper left, this is the right ventricle. And lower left, this is the right atrium. You can always tell the difference between the left ventricle and the right ventricle by the thickness of the myocardium. Remember that the left ventricle is muscular, and hence the myocardium is thicker than the right ventricle. Also remember that the right ventricular size is about half or 0.7 of the left ventricular size. To make it easy for you to remember, if the right ventricle is the same size of the left ventricle, you need to think that something is wrong. One of the most common pathologies that we see that can cause right ventricular enlargement is PE or pulmonary embolism. This is a video of the apical or four-chamber view. On the right lower side you've got the left atrium, right upper you've got the left ventricle. You can see the mitral valve there, and then on the left lower side of the screen you can see the right atrium, and then left upper you can see the right ventricle, and you can see that it's about half the size of the left ventricle and not as thick myocardium there as in the left ventricle. Another video of the apical view, and you can see here that the left ventricle on the upper right side of the screen is massive and dilated and almost taking the whole of the screen, and that's of course not normal. And that's why in this particular view it couldn't get everything, and by everything I mean the apex of the heart, but you can see still the four chambers, which is the right atrium on the left lower, right ventricle in the upper left of the screen, and left ventricle on the upper right side of the screen, and the left atrium on the lower right side of the screen. It can be tricky sometimes to acquire an apical view, so you can always slide the probe around the point of maximal impulse. And again, if the patient is well enough, ask him or her to lie in a left lateral position or sit forwards. And by that way you can bring the heart nearer to the chest wall, and hence getting better views. Moving to the last view, which is the subcostal or subxiphoid view. Place the probe in the subxiphoid position, aiming towards the left shoulder. Try and make the probe as flat as possible to the abdominal wall. Usually it's 10 to 15 degrees, but it's acceptable to make it totally flat. The probe indicator should be pointing towards the patient's left side. This is the view that you will see in the subcostal view. And basically you will be seeing a 4-chamber view, but a bit rotated. And notice that you're using the liver as an acoustic window. So again, here the LV is your left ventricle, LA is your left atrium, RV is your right ventricle, and RA is your right atrium. And the liver is on the left side of your view. Here you can see a video of a subcostal view. On the right side you've got the left ventricle, and on the left lower side you've got your left atrium, and then the right ventricle and right atrium is above them. In the subcostal view, if you rotate your probe 90 degrees anti-clockwise, you might be able to get this view, which is the view of the IVC going into the right atrium. And this is the kind of the start of the right atrium on the right side of the screen, which is the bit balloon there. You can always use this view to assess the intravascular status and whether the patient is intravascularly depleted or overloaded. And of course, clinical correlation is crucial, and you can't use ultrasound or echo alone to determine this condition. To get a decent subcostal views, you need to adjust the depth, and you might need to flatten the probe as we mentioned on the abdominal wall. You can always slide the probe towards the right side to make use of the liver as an acoustic shadow or acoustic window. If possible, you can ask the patient to bend his or her knees to relax the abdominal wall muscles. Remember that although theoretical knowledge is important, practicing is very crucial when it comes to using ultrasound. So at the end of this presentation, I hope that helps, and thank you very much for listening.